We are having a discussion today on growth modulation, and we have an expert and the originator of the technique, Professor Peter Stevens, with us. So we have a very different session that we are not going to have lectures, but instead of that, we are going to ask questions to the professor. And these questions are not very high-fi level questions, but what problems we come across in day-to-day practice that we are going to ask. So welcome, Professor Stevens, to this meeting, and we start the ball rolling without wasting much time. And I think that Professor Stevens doesn't need any introduction. When I said that he's the person who revolutionized the growth modulation with the help of 8-plate. So that's, I think, the best introduction about Professor. So let's start with the first question. And the first question is, when there is a lot of limb-length discrepancy or a lot of deformity, and when we want to keep an implant for longer period, because deformity correction or the limb-length discrepancy will take a longer time. So in that case, we are trying to apply the implants across the physis for long period. And sometimes it is more than 2 years. So what are your understanding about this? Like, can we keep it for a longer period, or when the 2 years are over, we have to remove one of the screw, allow some time to pass, and then to continue the deformity correction or the limb-length discrepancy again? So what do you think about that, and what are your ideas?
Well, the 2-year limit is empirical. I researched it, and the best I could find is that it was based upon a communication between Dr. Femister in Chicago and Dr. Blount in Milwaukee, and it was never proven or disproven. But in my own practice, I adhered to that for limb length problems, for gigantism and syndromes. So I might start as young as age 3, insert in Klippel Ternani Weber, for example, and put in femoral. I have a little model here too. I'm sure you've all seen these before, but put in femur and tibial plates if needed. That's the wrong model, this one. Put them at both levels if needed, depending on the segmental difference. But at 2 years, I routinely, for length, would remove the metaphyseal screw, wait 6 months, and put it back in. In doing that, I never had an arrest. Now, could I have waited 3 years or 4 years? I think there comes a time where the physis would close. But 2 years I know is safe because I've done it many times. In contradistinction, for angular correction, there is no limit. For something like achondroplasia, it might take 3 or 4 years with one plate. As long as it's in good position, you don't need to move it. But I subscribe to the second philosophy that you mentioned, which is intermittent removal of the metaphyseal screw, with the caveat that the plates need to be in good position. If you leave the plate in epiphyseal screw, if the epiphyseal screw has dragged across the physis, then you take the whole thing out. But otherwise, you can leave it in with one screw.
Okay, fine. So just to summarize what you said, I would repeat it so that it becomes clear to everyone. The first, the 2 years is an empirical statement.
Mm-hmm.
That's the first thing. The second thing, you have done it for more than 2 years for the angular deformity, like a condition, achondroplasia, where anyway the correction is slower. No one has done yet for limb-length discrepancy. And it's your practice that you remove one of the screw by the end of 2 years, and then you reinsert it. The gap, what is the duration between the removal and the reinsertion? 6 months, 12 months?
6 months, but I want to add a comment. When I'm putting it in for length inhibition, I put the screws divergent at the outset, because if we put them in parallel, they will diverge and you're wasting some time, and there may be central growth in the physis. So for length applications, I place the screws divergent at the beginning. For angle, I place them parallel.
Okay, right. So that's the first very simple point. Coming to the second point, and that point is about the purchase. Whenever we put a screw, ultimately the implants are pulled by the bone, and somehow our Indian patients' bone are not that dense as the Western population. That's what my perception is. And as an orthopedic surgeon, we would always incline to put a longer screw so that we have a better purchase. So do you have any idea, or do you know any study which says that the 50% of the width of the epiphysis or a metaphysis is sufficient for hold, or we can go beyond that also?
I think there's no absolute. I know if you use short screws, especially in the epiphysis, there may be only room for a short screw at the wrist or the ankle. It may drag across the physis and look like it becomes a transphyseal screw. So I put in the longest screw that I can. Half or more is fine. Longer screws have more purchase, and so that may be an advantage. There's no downside to using a long screw.
Okay, so basically, in the your system, it's up to the 36. So do you have something longer screw for like beyond that 40 or some size?
No, well, with Orthofix and the 8-plate, 32 is plenty. The only reason they came up with the screw length is I used to use blunt staples for a long time. And so I picked the 12, the plate dimensions kind of matched the staples I'd used, but 32 is sufficient. If you, I don't know what Umar or people in India make. If you have a longer screw, that's fine. I don't think there's an advantage when you go past 32, but there's no downside.
Downside. Okay. Before we move on, like anyone would like to ask questions related to this point about the screw length, or if you want to add your observation, please raise your hand, and then we would be happy to know about your views also.
Is there any difference between the angular correction and the limb length discrepancy screw size, or same?
Same. I used all 4 or 5. There are companies that make small fragment screws, and you don't need to size the implant to the patient. I used the same implant, the 8-plate with 4 or 5 screws. And my youngest patient was 18 months old, and my oldest, 18, and my biggest 400 pounds. You don't need bigger, stronger hardware for big kids because you're putting it in an intact bone. The plate can't sense or care what the BMI is. It's an important thing about, I'm sure we'll come to it, about broken screws is whatever size and whatever patient you're doing, make sure the plate is coapted to the bone, even if you have to bend the plate a little more to contour. Because if you leave a gap, you don't have a tension band, and the screw will have 3-point bending and can break, like in Blount's disease. It's almost always the metaphyseal screw, and there's almost always a gap, which is a surgical error, not a hardware error.
Okay. Coming to the third question, already partly you answered that question, but still I would like to repeat that question. That question is about the parallel screw and the divergent screw. So as you said, for a limb length discrepancy, you would start with a divergent screw.
Yes.
And for the deformity correction, you would go with a parallel screw with the idea that ultimately it would open up. Right? That's the concept. Now, if the child age is such that there is very limited period is remaining, particularly for the deformity correction, in that case, can we use a divergent screws to begin with so that the correction starts very quick?
That would not start the correction faster. I mean, you're theorizing that compressing the physis is faster than a tension band, which it's not. I can't cite the article, but there was an article that specifically studied that and found there is no advantage starting with divergent screws for angular correction. There might not be a disadvantage, but there's no advantage. And I will say that the plate is designed with a narrow waist so that if the screws reach their maximal divergence, then the plate can reverse bend, which it will. Broken plates are exceedingly rare. So if you feel inclined to put them in divergent, fine, but there's no proven reason to do so.
Okay. And that just one point related to this, like of late, you have changed the design of a plate and you have made it so that there is more divergent possible. What was the reason for that?
More flexibility, less stress on the hardware. So Those screws in the delta plate can diverge 60 degrees, which would surpass any of our needs. But the way that was done is just undercutting the underside of the hole at either end was undercut so the screws could spread wider. Really, you just want a tether. And, the veterinarians used to and maybe still use a wire and 2 screws, which is flexible, but wires around the knee aren't very good in kids. So flexibility is the goal by whatever means you choose.
Okay. Before that, I would like to ask a question like, say, when you decided to change the design, have you seen a screw breakage which made you to think that let's increase the plate design or change the plate design? Was what that the reason for that?
Orthofix asked me to come up with a different design so they could get an international patent. So the only thing I could think of, I said I can make it more complicated, but that's not going to do any good. So the only thing I could think of is make it more divergent. And so ironically, they did that, and then they tried to charge more money, and which was embarrassing. And my intent was curiosity, not driven by broken screws. And I will say, with a broken screw, there's no benefit to stacking plates because then you don't have a tension band, and there's no need for a quad plate, and there's no need for stainless steel, bigger diameter screws. Any of those will break if they're loaded improperly, as I mentioned. What you need to do is contour the plate and countersink the screw. If you have a broken screw, you only need to take out the screw head. You can leave the retained, most of these are titanium. You can leave a little piece of titanium in there forever. You don't need to go in there with a hollow drill and try to get it out. Just leave it alone, bypass it with another screw.
Okay, so according to you, all these ideas, the edge plate or that plate, are basically to bypass the patent laws.
Yes.
That's the reason.
Yes.
Okay, right. So there is no science behind that, but it's more of a okay.
Sorry.
Right. Yeah. Fine. So with that, I hand over to Hitesh for the further questions. Over to you, Hitesh.
I want to mention something I think I mentioned in the lecture, but fundamentally, I did blount staples for 20 years when they were falling into disfavor, and I kept doing them. And they said never do it under age 10. And the fear was, oh, the growth plate will close. The growth plate is more powerful in the young children than it is in the adolescent. It's more resilient. But there wasn't room to put 3 staples, which is the other reason. They said use 3 staples in a row to resist breakage and bending. Well, then you have 3 that can migrate or break or bend. But in young kids, there wasn't room for 3. So I put in 1 staple, maybe in a 4-year-old with Cosen's. And ironically, as the staple was failing, i.e. bending, the deformity was correcting rapidly. The trouble is I couldn't predict whether it would break or migrate, while it's bending. So that led to the idea of not scientific, just observational. We need something that's flexible, that won't migrate, and generally won't break, but will bend. So that's the fundamental rationale behind the whole thing.
Okay, before I hand over to Hitesh, I had a question. Like your system is cannulated. Now,
Is what?
is cannulated. Like say you pass
Yes,
a wire
yeah.
and over
Yeah.
that you pass. Now with so much of experience, are you not able to straightway drill and then pass the screw? Is it not possible for you with such experience?
Oh, to use a solid screw?
No. Yeah, solid screw. Exactly. The solid screw,
Yeah.
because it's a stronger one.
Well, I'm told it's 40% stronger or something, in 3-point bending, but these aren't loaded in 3-point bending, and there's no advantage. And the disadvantage is getting them out. So I can remove cannulated screws every time with a C-arm and a guide pin and stick it in the screw, and the screw head won't strip. When you have a guide pin in there and you tap on the screwdriver, it's countersunk and it comes out every single time without fail. The solid screws, good luck getting them out percutaneously without stripping or having issues. So think about removal. The strength is sufficient, and the advantage is accurate placement and ease of removal.
Okay, right. Okay. Yeah, over to you, Hitesh.
Yeah, thank you for giving the idea for the size of the screw. My question is what should be the optimum length of the plate And longer plate makes the surgery easier? Does it change with the length of the plate, or is it only standard?
Whatever you're comfortable with. I only had the 12 and 16 millimeter because I was mimicking 3/8 and 5/8 mount staples, which in 20 years of my practice were sufficient. Companies have come out with even longer plates. That's fine. And some of the dysplasias or metabolic things, you have a very wide physis. And if you have a wider plate and want to use it, that's for the surgeon's comfort, it's fine. For the degree of correction, it won't matter, of course.
Did you keep it any rule for the length and the width?
No,
or the
no rule. No, intuition
Okay.
and observation. And as mentioned, like again, at the ankle, parenthetically, I used transphyseal screws at the ankle starting in 1985 with a little bit of guilt because I was told never to put a threaded device across the physis. But it worked well. However, the screws can bend or break and be hard to get out. So I then switched to the 8 plate. But in things like hereditary multiple exostoses, the lateral epiphysis is so narrow, you can't get a long screw in there. So I'd use a shorter screw and it worked. But if it started to drag upward, then I would exchange the screw or move the plate, as needed, which wasn't that often.
Okay. Yeah, thank you. That's the next question is there. It's burning question for almost all.
Hitesh,
Yeah.
before that, the reason for using a longer implant is that when we remove one screw, and if we have a longer plate, then probably the plate coming on the physis are less. So that's the reason.
I agree. You could have more leeway. The purchase of the epiphyseal screw, as you put it in, you'll notice that bone is all cancellous, of course. It's never quite as convincing as the metaphyseal screw. And I agree that perhaps the longer screw and the longest screw you can and a longer plate give you more latitude.
Yeah.
Yeah, Hitesh, please.
Yeah. The next question is very important, that when the correction takes place, when do you suggest to remove the plate? Because that is really very burning question. And
yes,
the two important question for that how much rebound growth and how much is loss of correction one can anticipate and expect, actually, because this is a very, very important question for almost all practitioners.
Right. So early in my practice, I used the mechanical axis, divided the knee into 4 quadrants, zones, so to speak. Zone 1 generally wouldn't have surgery, just observation. Zone 2 would be the medial or lateral quadrant needing surgery, and zone 3 is outside the knee. So if I was correcting, say, valgus, zone 2 or 3, I would allow them to go into not only neutral, but medial zone 1, slight overcorrection, and take the plate out. That was early in my practice. And I can't give you statistics as to say how satisfactory that was. But once I realized, well, wait a minute, I can just take out a metaphyseal screw percutaneously and put it back in. Yes, it's an anesthetic. It takes 5 minutes. But I switched to when the knees and ankles touch and the parents are happy, I give them a choice. I can take the implants out. I can wait 3 months and take them out, or I can take out a screw. And they usually went for just take out a screw. And I can segue into saying the best way to watch for rebound and prevent overcorrection and so on is smartphone pictures once a month from the parents. They're very compliant and very happy to do it. They all like to take pictures of their kids and share them. And then it puts the responsibility upon them. They don't have to travel through traffic and whatever, and have a routine x-ray every 3 months for something that might correct in 4 months or 20 months. So what I switched from is slight overcorrection to take it to neutral, take out a screw, stay in touch with smartphone pictures. If it's recurring or overcorrecting, come back and insert a screw or take out a plate or whatever. It's very easy to manage, and it solves all those questions. We can't predict rebound. If you wanted to predict rebound, then you need to say, well, your child has genu valgum. She's 8 years old. Let's wait till she's 11, and then we'll put these in, and everything will be perfect. Doesn't work that way. Not in our society. Better to treat. And plus, while you're waiting, there's damage. They have a for genu valgum, they have a circumduction gait, they have patellofemoral malalignment. Some of them can have ACL injuries while you're waiting for some prescribed time to do the right thing. So just do it, straighten out their legs. The parents know what it involves to do it again. And I had a lot of second generation patients and some third generation. The parents all had osteotomies by me, and they forgave me because they were so happy that their kids needed 0 osteotomies for any condition you can think of, if the growth plates are open. Hip, knee, or ankle, elbow, wrist.
Yeah. Hitesh, sorry to interrupt, but again, I would like to ask on this. So clinical examination is not that reliable if we look at the hip to ankle axis, which is much more reliable. So
yes,
I've seen that many times when it looks clinically okay, and I send the patient for the hip to ankle X-ray, and still we find that there is either under correction, over correction. Very rarely it comes to the desired correction. So how many times you have seen this situation that the things has gone back, means like say whatever correction you have achieved, it has gone back by a few degrees? And what is the maximum loss of correction?
well, I show the parents what I do. I measure them, I look at them standing. I show the parents how to take the picture with shorts or whatever, with not the feet pointing forward necessarily, the knees pointing forward, because they may have torsion that throws everything off. I show them how to do it. They take a practice one in the office. I give them a placard and they can make their own copies and fill in the data. And so, but I also examine them prone on the table, because I'm going to do a prone torsional profile anyway, and I show them what I'm doing. And when they're prone, sometimes when they're standing, they're on their best behavior. They'll try to force their legs straight because they know you're looking. But when they're prone, you can cross-check and say, okay, the knees and ankles are touching at the same time. Now, if that had been the case in the beginning, they wouldn't be in my office. If the parents don't perceive a deformity, they wouldn't be there. But I will say, if the ankles are separating or the knees are separating, and they can't touch simultaneously, in particular, if they're having evolving pain or difficulty running and playing, they need to come in for an X-ray to corroborate and likely surgery. And I often do it on the same visit. They may send me a picture and I say, yep, they need to come for the surgery we discussed or revision of it. I can tell in a picture whether they should be satisfied or not. I'm being facetious, but every parent wants their kids to have straight legs of equal length. We don't need X-rays every 3 months to prove that. We need X-rays at select times when things are changing, when they're getting worse, or they're overcorrecting or rebound, or whatever the case is. And the parents really appreciate, the terms are all in Latin. So I don't have it with me, but I have a pad. I probably showed it to you in Omnibod, showing a picture of the legs and what, quote, normal is. And then they'll have their X-ray, and I'll say, okay, well, this is normal, and there's a knock knee here, and there's the growth plate, and I put the staple there. So I give them a picture to reinforce what I say, because they're often worried about time and traffic and whatever. And the communication is important, even though the surgery is very subtle. It's actually more important. And in the same line of things, when the parents know that they're not going to exit the operating room with straight legs, they're still going to have a crooked leg. They didn't have an osteotomy like maybe the parent had. And they understand that, so they get involved. That doesn't mean they're not lost to follow-up and somebody doesn't come back sometime with significant overcorrection, but at least they'll say, oops, I forgot to take the pictures you told me to take. They accept some of the responsibility, which they should.
Yeah, compared to the rebound and recurrence, I have a question. When do you decide to go for the repeat surgery? It will wait for zone 2, because anytime it will rebound back, but when do you actually do the surgery?
Yeah, no, so then it's a game of how mature are they? If they have 2 years to grow, you might say, all right, send me more pictures, we'll know within 6 months. If they have less than a year to grow, I'll say you better come back and we'll put the screw back in or whatever. So part of it depends on the time remaining on the shot clock of growth.
Okay. And depends on the question with Dhiren Bhai, similarly that I'm asking, because the would your follow-up be same like 3 months or every 6 months or only clinical photograph?
Only clinical photographs. I've had patients who don't come in for a year. They have an
Okay.
X-ray in the beginning and have, and then they're scheduled to have surgery because they often, I don't know that they'll necessarily need it and they have to get it pre-authorized and insurance and all that. So they'll have the office visit and then the scheduled surgery. And then they might not come back for 9 or 12 or 15 months when the legs are straight with the surgery already pre-scheduled. Say on that trip to Salt Lake, we can do the surgery on the same, we'll get an X-ray, go downstairs, do the surgery, you go home. It's all outpatient. And they're more than happy to save the cost and travel and time off work.
Okay. Is the surgery of osteotomy and the growth modulation cost the same or it will be different in your healthcare system?
The surgery for osteotomy, pardon me?
Yeah.
Well,
Cost.
osteotomy is an
patient is this.
admission of defeat, but if the growth plate's closed, then they'll have an osteotomy. It's usually overnight, and they'll go home with a pain catheter, and hopefully, and usually crutches, hopefully no cast. That's in my own practice, which was probably 80% osteotomies, 90% when I started, and let's say 10% stapling. That flipped to in the last decade, not even 10% osteotomies, and almost everything else guided growth. It's like the more you do it, the more versatile you see it is, and the more satisfying.
Yes.
As opposed to the sports people, I call it go small or go home.
Yeah. Yeah, Dhiren bhai, you can ask now. Next question.
Another question which is very important and all of our fellows or the colleagues are interested about the post-op management. So how much pain they have and how long they get pain, because I've seen many children like limping for a 7 days, 10 days period after the 8 plate. That was not the case with PET screw, but with 8 plate, the pain persists for a longer period. So what is your experience?
So I set the parental expectations as best I can. I say the surgery is minimally invasive outpatient. The incision is, 2 or 3 centimeters long. That doesn't mean it's painless. Anytime you do surgery on the bone, it can be painful. And I tell them it will probably last for 2 or 3 weeks, but each week should improve. And I also tell them that if by 1 month after surgery, they can't bend the knee to 90 degrees, I'll send out a prescription for physical therapy. In other words, physical therapy won't help in the beginning. They're already scared and have some discomfort. And that might be not even 1 in 10, maybe 1 in 15 or less that benefit from physical therapy, whether it's necessary, they have somebody seeing them hands-on and they get reassurance, without coming back to the hospital. So I tell them it's not painless surgery, but it's a lot less painful than osteotomies. In my office, I had a model of 3 femurs, one with an 8-plate, one with a poodoo plate, and one with a external fixator. And I say, compared to these, it's a lot less painful. Now, on that topic, for fixed knee flexion deformity, I know the detractors of that say, oh, it's so painful. And it is because you're subretinacular and you have a fixed knee, you have the retinaculum going right over the hardware. The hardware is on either side of the sulcus. And so I show the families the model and I draw a picture and I say, tell your physical therapist that the crunching they hear is not hardware in the joint. It's the tendon rubbing on here. And yes, it will bother them for maybe 6 or 8 weeks, but again, way less than an osteotomy, which often recur, and obviates bracing. And it's worth it basically. So you have to educate the parents as to be realistic. Ice packs help, whatever pain medication you think is appropriate, and that's all you need to do in physical therapy for the minority. And again, nothing we do is painless. Nothing that works is painless. So compared to the other options, it's the best way to go. And the parents who had osteotomies certainly recognize that because they often had spica casts and non-weight bearing and a bunch of x-rays to show healing. So they get it right away. But the others come thinking, oh, look how cute it is, you know, and it probably won't hurt. It does hurt. Now, on the flip side, I say they can resume any sport they want as soon as they're comfortable. It could be 2 weeks, it could be 6 or 8 weeks, but when they're comfortable, there's no limitation. They're not going to break the hardware. The hardware is protected by the bone. It's literally bomb-proof.
Okay, at this stage, I would like to tell you about a trick. It's not a trick, but it's the practice which I have adopted. I suggest anesthetists to give a short general inhalation anesthesia. After surgery, I inject the area, the operated site with the local anesthetic solution.
Yes, we do that.
Yeah, and
right,
then I allow the patient to walk soon after the surgery. So that gives them a lot of confidence that yes, they can bear weight. No doubt, I know that that lasts only for 4 hours, and after that the pain cycle starts. But in that 4 hours, they are walking, and that gives them a lot of confidence.
I think I do the same. I agree. I failed to mention it.
Okay, fine, good. So then coming to another difficult question, and that's the speed of correction for a condition like achondroplasia or multiple exostosis. So how long you keep and how do you tell patient that it's going to take this much time? Because a 10-degree correction for some other condition and for the multiple exostosis are very different.
Yes. Well, again, I explained to the parents, let's say with achondroplasia, you know, if they want cosmetic lengthening, I can refer them to somebody else. Nobody in Utah does that. The bones could be cut and stretched, so they could be straighter and as tall as you want, albeit at a very great cost, and so on. Very few takers for that. And then I say, I could do an osteotomy for immediate straightening, but you know, I have the model. It's a much more invasive. I can do the plates. It's going to be slow, but at least you won't notice a difference month to month. But at 6-month intervals, you'll notice, hey, the legs are straighter than they used to be. And that's the advantage of taking pictures, because they can put them on their refrigerator and say, it is working. We don't need to worry and go back and get an X-ray. As long as they see a trend of improvement, albeit slow, they're always accepting of that compared to the alternatives. So it's an educational thing. And, you know, although the surgery is short, the education is just maybe more important than doing osteotomies, where I'll do carpentry and we'll fix it. You know, I say, we're going to do some gardening and it's going to take some time and patience, which surgeons and parents sometimes don't have, but they can learn.
No, my question is slightly different. How do you predict that this is going to take this much time for corrections?
I don't. Well, no, let me say that in idiopathic conditions, you know, it's about a degree. The distal femur grows 9 millimeters a year, and you get about 9 degrees of correction. But you throw all that out the window with achondroplasia and so on. It's just slower, or metabolic conditions. I can't predict the time, but the time doesn't matter, especially if they don't have to come back every 3 months just to say, oh, it's a little better, see the X-ray. You know, if they're nervous, they can come back, but they quickly learn that it's not worth a long trip and all the hassle just to prove what we can see visually.
Okay, then the next question is related to the new indications which are coming up only in last 5-7 years, and that's the posteromedial bowing and anterolateral bowing correction by growth modulation. So particularly now we are doing it for our younger and younger kids. And in that case, particularly for the distal tibia, it's very difficult to pass a 4.5 mm screw. So can we use on the metaphyseal side 4.5 and on a epiphyseal side the 3.5 screw for the distal tibia?
Of course, yes, you can. And I don't know if you've seen it, but Mark Dahl had a very impressive manuscript on NF1, neurofibromatosis. And, you know, what I've observed in general, we're taught about Cora deformity analysis, and you have to correct at the apex of the deformity. Sometimes you can't, and sometimes you shouldn't. The advantage of 8 plates in general for these conditions is the Cora is at the epiphysis, and no osteotomy can be at the Cora. And so for oblique plane deformities, posteromedial, posterolateral, and you don't have to do like CT scans and fancy planning. You rotate the limb till you see the most obvious deformity and you put it at that apex. And the other thing is that with Wolff's Law, if you can restore the mechanical axis, Wolff's Law may produce significant diaphyseal remodeling. You don't have to, well, let's say with rickets, you may have bowing of the diaphyses. You can ignore that as long as you maintain the mechanical axis. Doesn't matter if you have a femoral bow, interlateral femoral bow and rickets, it looks like you have large quadriceps. It has no effect upon gait or function if the mechanical axis is restored. So you can ignore the chora or observe it, whatever you want to do, but the power of guided growth exceeds the power of many of our well-intended osteotomies.
Okay, just a continuation of that. On one side, we are using a 4.5 screw, and the distally we are using a 3.5 screw. So will it have any effect, like say the asymmetrical screw size will have any effect on the plate or the plate breakage or something like that?
I don't believe it would. I didn't do it myself. I have no objection to it. So the space available and not having a prominent screw head may dictate what you choose, but the effect of the tension band will still be there, even if you have different size screws. Yep.
Okay. Then the concept which you launched later on, that's the sleeper plate. So first of all, we would like to know the difference of, the concept of sleeper plate. And then what are the pros and cons? Like, does it work in 100% of cases if required? Or like say when it comes for the second surgery, you feel that there is no proper length and you need to change the plate. How many times this has happened?
The only time I change the plate would be if, well, let's say you take out a metaphyseal screw and they have continued tethering and overcorrection, then I take out the whole plate. And you may blame it on some bone that built up over the plate. You may try to figure out why it's doing it. There's that situation. The other situation is that if the epiphyseal screw has dragged upward or downward and is close to or across the physis, I take it out. Or take it out and put it in, reposition it with new screws. So it's a judgment call. But sleeper plates in my practice were always gratifying. And the rate of overcorrection in the ones I followed was quite acceptable, maybe 1 in 15. But you have to compare it to, should the other 14 patients have to come back and have a new plate put in? It's kind of a democracy. Like, what's good for the general rule? And I think sleeper plates are fine. I know that's been contested. Even my partner presented a paper at POSNA, and possibly some of those were my patients. But again, I would involve the parents in the follow-up. And if you intercept a sleeper plate issue within 6 months of its evolution, you're not going to be in any serious trouble. I did no osteotomies as a result of sleeper plates.
This law was given by CM Bulldog.
Then the next question is about, like you have made the screw which you have removed. So there is a hole over there. Then with some growth, now the plate hole has migrated proximally.
Yeah.
Then you put a second screw. Is there any problem in the purchase of that screw when you insert it for the second time?
No problem at all.
Okay, right. Fine. So
it's fun to see that you can see the hole migrate and show it to the parents on an X-ray, and they always get a kick out of it. Like, yeah, they're still growing.
Okay, right. Yeah. Over to you, Hitesh, for the further questions.
Yeah, thank you. You have already shown your preferred method for correction of FFD knee, anteromedial and anterolateral. But the Van Harold Bose has come with the technique medial and lateral rather than anteromedial and anterolateral. What do you think? So the pain would be less, whether it will be effective or it will not be effective?
I think there'd probably less pain because you don't have the retinaculum stretched over the fixed knee. It doesn't make sense why it would work. The closer you are to mid-sagittal, you'll inhibit the length, rather than improve the angle. And nor would you put a central plate, you know, it would be under the patella. So I'll stick to, I make two incisions, and I open the retinaculum, and I can see the articular cartilage of the sulcus, and I can say to the resident, the plate's going to go just lateral to that. And I've always been happy with that. And I know there are proponents of doing the transphyseal screw instead. I agree. It's simple to insert one screw. It takes, you know, a shorter time. However, why violate a physis if you don't have to? And you don't have to. And number two, the cora of correction is within the physis for the transphyseal screw rather than at the perimeter. When you put in a plate and two screws, if the screws are parallel, the cora is in hyperspace. It moves toward the bone as the screws diverge. Whereas if you tether the physis itself, it's less mechanically advantageous. Yes, it works. Stress fractures of the femur have been reported. Difficult screw removal has also been reported. You have to use large, preferably 6.5 fully threaded screws. Why put 13 millimeters of insult across a physis that's already not that healthy? So I don't think it's advantageous at all, but that's just my observation.
Yeah, but coming to that point, anterior screw, do you find any difficulty in removing? Because we have got a lot of issues with the popliteal pterygium and FFD, where severity of knee flexion deformity is huge. It will get totally buried, the anterior plate.
I haven't had trouble removing plates. I've never used the transphyseal screws at the knee. So the plates are,
Okay.
you know, again, they're cannulated. The holes are cannulated in the screws, and you have the C-arm handy, and you can, yeah, it's fine to just make an incision and find the plate and take it out. But you can use the C-arm to find hardware that's otherwise difficult to find. I don't have any trouble with it. And I haven't seen a lot in the way of recurrence of fixed deformity with guided growth as opposed to osteotomies. Osteotomies almost always will recur because you're up in the metaphysis somewhere and you stimulate the growth with the periosteal stripping and they grow back into flexion. The other thing I didn't, you know, early on, I used to do a lot of hamstring lengthening in CP and put them prone and lengthen the hamstrings, distal lengthening. And if you correct the fixed knee flexion deformity, and we did gait analysis and published it, you get benefits at the lumbar spine, hip, knee, and ankle, all by straightening the knee. And I said to the parents, I'll lengthen the hamstrings later if I have to, when I take the plate out, and I didn't have to lengthen the hamstrings. After all, the hamstrings are 30% of hip extension. And if you lengthen them distally, you may lose some hip extension and aggravate hip flexion deformity.
Okay.
Professor Stevens, I have some questions. See, whenever we say there is a flexion deformity at the knee, the rule is like if there is a soft tissue problem, we try to correct it first. And whatever is the capsular contracture, that we correct with the 8 plate. So what you said is like, you said that you will correct the bony component or the capsular component first. And then in most of the cases, you don't require the hamstring lengthening.
Yeah, so I inverted what you said is what I used to do. However, if you put the patient, when you do a straight leg raise in CP, I call it a bent leg raise because they can't straighten their legs. But anyway, it's misleading. It's not that helpful. If you put them prone and you have their knees at the edge of the mattress, the padded table, or close to it, and they can't put the tibia down, that's the fixed component. That's not, the hips are extended when they're prone. It's not the hamstrings that are causing the fixed knee flexion. And yes, it could be capsule, but I don't release the capsule and do all that. I address the guided growth to correct the fixed component, and then I reassess the muscles. And of course, in our country, a lot of these patients are receiving Botox and, you know, baclofen, whatever, as well as therapy. And you know, we know bracing doesn't really work, but some of them have braces. Some of them get out of their braces once their fixed knee is straight. There's no brace that will correct the fixed knee flexion deformity. So in summary, I do the opposite. I put them prone. If they can't fully extend the knee, and you know, if it's 15 degrees or more, if it's 10 degrees, I wouldn't do anything. It's to the bone. If it's 15 degrees or more, I point it out to the families. put in the anterior 8 plates until the legs are straight, and then make further decisions from there.
Okay, you said 15 plus. Up to what degree you would rely on this?
Well, 45, I suppose. I mean, it depends on how much growth they have. I've had some patients hit a growth spurt. And also, these patients are often growing until they're almost 20. So the window, there's rarely a need other than arthrogryposis or spina bifida. In CP, this problem doesn't evolve till they're about 10. So most of them are, 10, 12, 13, but some of them are 16 or 17, because if they have some growth remaining, it's worth correcting some of that as much as you can in the unpredictable time remaining, rather than subject them to an osteotomy. And at maturity, you could do extension osteotomies and they won't reoccur. So, whether you're buying time or whether it's definitive, just depends.
Yeah. The next question I'll ask that you have done some work that you can throw the light that how can we use the growth modulation for torsional correction?
Yes. So you probably read a manuscript here or there. I've been to a meeting, and I will say, I've forgotten, Dhiren, if I sent you some additional slides, but I will on torsion. Things that have been published are put 8 plates on oblique mirror image on either side of the femur or tibia. Put cannulated screw and cerclage wire, which Metazao and some Argentinians published. You can disconnect a pega plate like Dror Paley did and hook it up with fiber wire. And now Orthopaedics has what they call the gyro, GIRO system. It's interesting that in the patent and on their website, they don't promote the use of this for torsion. They say you can use it for length inhibition. And the caveat is that the reason is, because I asked them, the FDA said, well, you can't prove it. The FDA is an obstacle. I'm working on that as we speak, not with Orthopaedics, but with another even better option, because those 3 options that I mentioned, all those require parental compliance and close follow-up, because once they're untwisted, you effectively inhibit their growth. So they'll either have a limb length inequality or they'll be shorter, neither one of which the parents want. So let's pretend that you have COVID, or somebody loses their job at insurance, or they move or get divorced. They don't come back. Well, the kid suffers the consequences of permanent arrest. So what I have, and I can tell you, I've got a very crude model. Hang on.
So once we have the questions which we have sent to Professor are over, we will take the questions from the chat box.
So you probably can't see this very well, but these are ultra high molecular polyethylene straps. So if you put them in obliquely like an 8 plate, then as it grows, they will become vertical. And because the physis generates 500 newtons of force, they'll stretch and rupture. So they won't get a growth arrest.
Okay.
But
becomes optional.
Yeah, but what you calculated 500 newtons, that may vary with the age of the child, the weight
the diagnosis. Yeah, the diagnosis. But you could make wimpy straps. You can make them lightweight for CP and so on. And you could also remove them. You could say, I want to see you when you're happy with the rotation, when they're not pointing in or pointing out, or when you're happy, and I show them how to do the rotational exam. I show them how to do the thigh-foot axis. It takes about 30 seconds, and how to metronome the femur and say, here's where they are now. When you're happy, come back and we can decide whether to take out the hardware. You can still take an x-ray. You can prove things with an x-ray or to their satisfaction, but if they don't, at least there's a out. Because polyethylene will stretch. And it might be it's 300 newtons. We've tested them on the Instron, and it started out at 700 newtons before they ruptured. So we made some modifications and we're down to 350. You could make them custom made so they'll rupture at 200 newtons. The newtons don't increase while the straps are oblique until they're almost vertical. Once they're about 20 degrees above vertical, then the forces start to increase. And when they're vertical, it increases exponentially. So they can be tailor-made.
Okay, so at what stage of the development it is? Is it available for the clinical use?
Almost. There's, and by the way, I haven't talked to the details, but I have discussed this with UMA Medical, and they may have it. They don't have the final design and the details, but I planted the idea, and I would think Girish Gangan at UMA would be a good resource. If when I have it finished, I'm happy to send him the final design. I have the final design, but I'm happy to share it. And I don't know what the process is in India, but I know I personally obtained FDA approval for the 8-plate as an individual surgeon. That's impossible now. It's a lot more expensive even to talk to them. Maybe with the new president, he'll disband the FDA. I don't know, but or Kennedy will. But anyway, but I have help in the right places, and there's a implant company startup that is very interested, and they have the wherewithal to finish the FDA approval. And my point to the FDA is, you need to make sure the implant is safe material and safe to use, but the direction we use it is up to us. Whether it's length, angle, or rotation doesn't matter, shouldn't matter. So I think I can overcome the obstacle by this summer. I think by this summer, they'll be available in the US, and I don't know about India soon. But the caveat is, do you see much slip to pivot in India? You probably don't have obesity like we do.
Yeah, we see. Yeah, we see.
So that I'm going to change the name of that to PFAR, proximal femoral acquired retroversion, because it's a rotational deformity, period. The varus extension is what we see on an X-ray, but X-rays are two-dimensional. CT scan and 3D reconstruction only shows the proximal femur with no regard to the condylar axis. If you image the whole femur, you'll see every time that acquired retroversion, that's why they have knee pain. That's why they have FAI, because they can't flex their hip neutral. So when you pin the skiffy, you put oblique plates in the opposite direction distally. Most of these kids have a year or more to grow, and then they can untwist to where the bump is lateral rather than anterior. They don't impinge and they don't need surgery. So I'll send you pictures of that. Did I already send you some? I don't think I did.
No. I think
Okay,
the one which, yeah, I think you sent one article related to that. Yes, yeah.
I did send an article about rotational osteotomy because I got burned doing a modified done, and the femoral head landed on the floor, and I almost had an arrhythmia, and decided I'm never doing that again. So what else can I do? I switched to doing mid-shaft osteotomy 10 years ago, more, and got excellent results without the worry in the osteonecrosis and the proximal femur issues, deformities. So I switched to that. And so now in lieu of an osteotomy, you just untwist it with guided growth.
Yeah. Thank you. For my last question, that we do see the femoral head valgus, caput valgum. We routinely do the transfacial screw.
Yeah.
Can we use the 8-plate for that? What is your thought on that?
No, you can't. You'd have to go intercapsular to be in harm's way. But when you do the screw, at first, when I did that, I thought I'll put it as medial as I can for the same reason that the cora is, you get more rapid correction. The problem is the more medial you go, the less purchase. You want to get at least 2 or 3 threads past the physis. And there's not a lot of room. So some of them outgrew the initial screw. So now it's better you could even do the central one if you want. My partner has done that in some skiffy patients in the contralateral hip. Or I go to the junction between the medial and the center third. And you do an arthrogram, and you'll find that when you use cannulated, fully threaded screws, and you can get an additional thread or 2 in there without violating the articular surface if the arthrogram shows that there's space. There's unossified cartilage that will give you good purchase. So yes, I like that a lot for CP and hereditary multiple exostoses and any other cause of coxa-valga. Again, if you do the varus osteotomy, in DDH too, varus osteotomy, they'll often outgrow that because they have regional acceleratory growth. It's sort of the cousins of the hip. And they grow back into valgus, so you have to do another osteotomy. So that's when I switched to, after I did 2 osteotomies on a girl, I said, I can't do a third one. I'm going to do a screw. And that was very satisfying.
Yeah, now let's take a few of the audience questions which are there on the chat. And I would request Dr. Vidyasagar to unmute himself and start a camera. Yeah, Vidya, please unmute yourself and start the camera and ask the question.
Just a minute. The
Yeah.
kids are crying in this room.
Yeah, I will read out the Vidyasagar's question. Would you steel plate cut down and titanium plates makes a big difference when correcting LLD, limb length discrepancy or angular problem? Whether he's asking whether the stainless steel and titanium makes any difference with limb length discrepancy and angular deformity, and thought about 1/3 of tubular plate and recon plate, type of the modification or growth modulation.
So 1/3 tubular and recon are plates that I did before I came up with the 8 plate, and they are each too rigid and too bulky that the screws stick out too much. And so I flattened an 8 plate in a vise, and so that would be wimpy and could bend. But when you flatten the 8 plate, it changes the shape of the screw hole and the screw head may pull through. So that wasn't good. So I discarded those in favor of the regular plate. And what was the first part of the question again?
It's
Yeah,
stainless.
the titanium or the steel, whether the metal does.
Well, yeah, titanium is better, and for 2 reasons. One is when you put in the screws, if you alternately tighten the screws, the titanium contours nicely to the bone. You know, it wraps around the bone better. And 2 is if they need an MRI, you don't have to take a plate out.
Okay.
So
good.
I know they both work. And when Orthopedics knocked off the 8 plate, they claimed that stainless steel was better, but it's not.
Okay, then there is a very good practical question by Dr. Anil Agrawal. Which parameter do you use to decide that the growth, how much years of growth remaining at the knee joint?
Well, I use a hand film and I look at the parents and see how much taller they are than the kid. And my feeling is, and the other thing is, in some conditions, when you take a full-length AP view of the legs, you might think a physis is closed, like in Blount's. So in those cases, I closely look at the lateral view, make sure I can see the whole physis, or even look at them under the fluoroscope at different angles. And if I can see the physis and think there isn't a bar, and they have at least a year to grow, then those are my parameters. If they have less than a year, yeah, it depends. You know, I might, like Virginia valgum, if they have less than a year to grow, I might say, well, we could do the femur and tibia and try to get them in improve them by a zone or 2. You know, we can try, but don't know. And then I didn't have anywhere I ran out of time. I guess with at least a year to grow, I think you're in safe territory to make it worthwhile and postpone or prevent an osteotomy.
Okay, and then there is a question of how to remove anterior plates for the FFD knee, because they get inserted deep in with time. So they are buried in the bone. So how do you remove the plates? Do you have any difficulty?
Yeah. So there, let me grab one more thing.
Remember, time is 10 o'clock, almost 9:59.
Yeah, fine. We will take 1 or 2 questions and then.
So if it's buried in the bone, I rely on the C-arm to help. That's where the cannulated screws really help. Get a guide pin in, get that metaphyseal screw out, put a tonsil forceps in the hole and pry it outward so it's lifted away from the bone a little. And then I took a kerosene rongeur and this one got bent, but drilled a hole in it so I could grab the plate at the metaphyseal end that's sticking out a little, take out the epiphyseal screw and pull it out. So rather than taking the chisel, and I try to do it that way through the cannulation, the tonsil forceps, and grabbing it with whatever forceps you have. And kerosene was kind of handy. And you know, then the decision, if one plate's buried and there's an angular deformity, whether to replace the plate on the other side or wait and hope you don't have to do an osteotomy. You know, there's a lot of gray zone. I didn't have many buried plates, but occasionally it can happen. And it's important not to elevate the periosteum when you put them in. So in theory, if you don't disturb the periosteum, you shouldn't have bony overgrowth, but sometimes you can.
Okay, then there is a question about the correction of the cubitus varus. I think that growth modulation is not very effective for correcting the cubitus varus, probably because the growth at the distal end of the humerus is not adequate. What are your ideas about that?
I think it has good potential if you do it before the age of 8. And,
Okay.
it grows slowly. First of all, the cubitus varus is not from a tether. The worst varus generally stops around 25 degrees. And if you x-ray an AP of the opposite elbow, you'll find that the varus it's like Cosen's, like Harold Frost described. It's regional overgrowth. It's varus. You see enlargement of the capitellum and sometimes the radius of the lateral side of the elbow is overgrown. So logically, it makes sense to tether that. But the window is best at age 6 or 7, knowing that at least they have potentially several years to grow, 6 or 7 or 8 more years. And again, to mitigate against osteotomy and postpone it until they're closer to maturity. And Ippolito published an article in Italy where they studied adults who had a correction of osteotomies for cubitus varus, and there was a high recurrence rate, which doesn't surprise me. So anything to put off an osteotomy is worth it. And they may improve to where they decide we don't want or need an osteotomy, or get close to maturity where you can do one that won't reoccur. So it's good, but if they're 10 years old, it's too late. It's got to be under 10, I think.
Okay, we are close. Our time is already, we are overshooting. So 2 quick questions. What is your experience with Blount disease, and at what earliest age you manage them with 8 plate?
So for Blount's disease, by the age of 2, you can generally tell whether it's Blount's or physiologic by serial x-rays or by whatever. So 2, and also for those who propose osteotomy, it's best to do it before the age of 4 to prevent recurrence. So 2, 3, 4 is a good age. I'll put it in at any age. If there's a medial bar that is defined by CT or MRI, you can excise the bar and put the plate. And I don't do anything to the fibula. I just put the plate on the tibia and make sure that the metaphyseal end is touching the bone, even if you have to bend the plate more. And just standard 8 plate with 4 or 5 screws, not stainless, not stacked, not quad plates. And worst case scenario, if you don't get improvement, you'll do the osteotomy they would have had otherwise. You haven't burned any bridges.
Okay, then the last question
is that the torsion and Blount's usually, and in anything, it may improve spontaneously as you correct the mechanical axis. So you don't have to put it in obliquely. You can if you want, but you don't have to.
Yeah, and then the question is, again, in obese children with big thigh, the X-ray look good, but clinically child has genu valgum. Is there any, in such cases, is there any higher risk of recurrence, or how do you counsel the parents?
Oh, in obese patients?
Yeah, those patients where X-ray looks good, but clinically there is slight valgus.
Yeah, well, I guess you could call it fat thigh syndrome. I mean, there's a lot of soft tissue there you can't account for, but some of them are so fat in the US that you can't, if you try to take a standing AP of both legs at the same time, it's misleading, whether it's Blount's or valgus. You may have to take an x-ray of one leg and an x-ray of the other leg for that very same reason, because they're forcing their ankles together to fit on the cassette. It's not going to happen. So, and a lot of them have some ligamentous laxity in play too, which can be deceiving. So my ultimate goal would be mechanical axis, medial and lateral zone 1, neutral is ideal. And then they'll just live with it. I don't want to give somebody genu varum to compensate for the big thighs.
Okay, and then there is a very interesting question, and I think that we should cover it. With sleeper plate concept, the epiphyseal screw is angulated. So in that case, would you like to remove it and insert a screw which is?
Well, so you're going to be replacing the metaphyseal screw, right? Oh, so if the epiphyseal screw,
epiphyseal screw,
it shouldn't angulate much unless you're doing it for length where you want it to be angulated, right? So it doesn't really matter. I mean, if you feel compelled to change it. It's percutaneous and easy to do because it's cannulated. So, but not required.
Okay. So with that, we had a wonderful discussion, and I'm sure that probably that will make this very important technique of deformity correction and the limb length equalization more precise and better. Thank you very much, Professor, for spending
You're welcome.
your
Nice to talk to you.
experience. Yeah. Thank you.
Have a good
And
day.
definitely
Okay.
we will have more sessions on that. Thank you once again.
All right.
Thank
Yep.
you.
Bye.
Thank you. Nice. Good day.
Bye.
Bye. Bye. Bye.